Welcome back on our osteocom video course on wisdom teeth removal. Today's topic is going to be about complications in oral surgery. What is our goal when we perform a surgery is to have an uneventful surgery with no complications. So today we're going to look about some complications and how to avoid them or how to react in case we have them. One of the first things they tell us when we do surgery is about the informed consent. Well, this paper, which can be oral but better if it's written, it is very important because the patient has to know before the surgery all the possibilities of doing the surgery or not doing the surgery, and also the possible complications that can occur during and after the surgery in order to be informed and in order to accept what is going to go and happen after the surgery. So it is very important to speak to the patient in the visit before the surgery in order to make him understand the importance of the things that he can do after the surgery to avoid these complications. So the post-op instructions are very important, and sometimes our patients forget the importance of these indications. So we have to act like surgeons and like surgeons, because we have to really focus on making them understand the importance of these instructions. So we have to give them some domiciliary prescriptions, and these may be like cold packs that have to be given for the first day, half an hour with and half an hour without, to avoid excessive cooling and icing of the skin, and a soft and cold diet in order to avoid excessive chewing on the surgical site, and so keeping the cold food in the mouth. Then we have to explain and tell them what they have to do in case of bleeding, because the patient at home can get afraid, and so we have to tell them that a normal pink saliva is something that can occur because the mucosa of the mouth doesn't react like the skin. So we're not going to have a scar tissue, but we're going to have a clot. And we know that if the patient rinses the mouth in the first 12 to 18 hours, then the clot dissolves and the bleeding starts again. So we have to tell them that they're going to refrain from rinsing in the first 12 to 18 hours, and in case of bleeding, they're going to have to place a gauze, a wet gauze, on the surgical site and make a compression for at least 20 minutes. And another important issue is to tell them that they have to stop smoking in at least for the first 24 hours, and this is exactly in relation to the cold packs that we give them, because the hot the hot sensation of the smoke on the area, and also the components in the nicotine and in the combustion of the cigarette, can cause a delay in the healing. And then we have to give them the rinses with chlorhexidine or any other mouthwash in case of allergies, that has to rinse and disinfect the surgical site for the week they're going to have the stitches. So now let's focus on some of these complications. One of them, for example, is the presence of root fragments in the surgical site. Well, this is a problem mainly due, if the fragment is small, to a lack of concentration in the phase of the revision of the extraction socket. We have to thoroughly rinse and check the socket once we perform the extraction, so as to remove any fragments that can remain inside the bone cavity and underneath the soft tissues, because this can create an infection in a second period. Obviously, if we look at these x-rays, we're going to see that this is not a fragment of a distraction. I mean, we left this fragment because we didn't perform a correct diagnosis and we didn't perform a correct execution of the surgery. So we're gonna have to treat this patient that refers to our office with the extraction of this root fragment, and this is not a intentional coronectomy to avoid risks of the inferior alveolar nerve. So we have to read our CT scan and look where the root is positioned, and after this we're going to perform our surgery. So we're going to make a small access flap, and in this case we're going to use piezoelectric instrumentation to create a space between the root and the surrounding bone, and here we're going to luxate the fragment, giving the possibility to remove the two particles of the two roots that have been separated to reduce the bone trauma, and then a complete revision of the bone cavity and a primary closure with silk for 0 stitches. What happens if we have bleeding, hemorrhages intra-operatively? Well, this is an issue that can frighten a little bit the dentist and the oral surgeon, and so we have to know how to deal with these kind of complications. Obviously, we can avoid these kind of issues by working with a subperiosteal intervention. So we know that the majority of the vessels run above the periosteum. So if we completely detach the flap with the whole periosteum, we know that the vessels are going to be protected by our elevators, and they're going to be protected during our procedures. So we have to protect this area with periosteal elevators or protectors, and in case of a normal bleeding we can also make some compression with tranexamic acid and with some gauzes, and this usually stops the bleeding. But what if we are working close to vessels in the soft tissues? Well, in these cases we have to know that we can make some ligatures and block the vessels ahead and above the area that we're going to work on, and we can perform a cutting of the vessel by making these ligatures. But what happens when we find some intra-bony small alveolar vessels? Well, in these cases we can act by making the vessel collapse in the bone, and this is simply done by getting either a lever or an osteotome for the summer elevation, and with a small hammer give a gentle hit on the lever, so that the lever makes the vessel collapse inside the bony wall, and this will stop the bleeding. Another important issue that is not very important for the result of the surgery, but can lead to problems and painful problems to our patient is the overheating lesions. We see an overheating lesion in this area, but one of the most painful overheating lesion is this one on the lip. This is just after the surgery, and this is 1 week later. Well, the patient is going to remember more about this lesion than of the whole surgery. So how can we avoid these kind of overheating lesions? Well, we have to perform a good protection. And here we have two examples of how not to use the hand pieces and the bars and how to use it correctly. So we have to create a shield of protection between our rotating bar, which is rotating, but we, especially if we use loops for surgery, are very concentrated on the tip of the bar, whereas we are not concentrated on the stem, which is the part that gives the overheating lesion. So the important thing is always to work in a parallel and overlapping of the two instruments. The protection, which is kept under the bar, like in the image on the right, and the bar, which is rotating on top. And this will avoid any overheating lesion. Whereas if we work in a disparallel position, the bar can go and create that kind of lesion. So a protection is very, very important to avoid these kind of complications. What about the bishabula herniation? This may happen when we are treating upper wisdom teeth, and it can be avoided in mainly in the majority of the instances by working always, as we said, under the periosteum, avoiding releasing incisions that are too deep and too posterior, and especially the ones that aren't completely on the bone plate. So we have to feel that the blade in the incision goes and cut deeply, cutting and bone sounding the underlying bone. It is very important not to work in a mixed cut, so just on the soft tissue, because this may lead to the herniation of the bishabula. So we have to raise a full thickness flap and keep our elevators and protectors on the bone. The elevator has to touch the bone so as to keep the soft tissues behind. But what happens if accidentally we expose the bola? Well, in these cases, it's not very useful to pull the bola out, because this will create an area which will reduce your visibility during the surgery. We can cut the small part of the bola that has herniated, and we can use this either using a bipolar forceps, or in the case we don't have a bipolar forceps, we can just heat with a Bunsen, for example, a tweezer, and we can just go and cut the bola by creating a heating of the area, and this usually manages to reduce the exposure of the bola and gives us the possibility to continue our surgery. And what about oral antral communications? Well, oral antral communications are something that can lead to oral antral fistula and problems with the sinus. So we have to create and do an accurate radiological diagnosis before extracting our teeth to see if there is a communication between the roots of the tooth that we're going to extract and the sinus. And then, in case of a communication, we have to either do a gentle Valsalva maneuver or use some blunt needle to probe the area and to see if we are inside the sinus. What can we do if we have this kind of communication? Well, we are going to use for communication smaller than 5 millimeter, just some collagen sponges to close the gap, and this usually permits a natural closure of the communication. Or in case of larger communications, we're going to perform a Rareman flap to primary close this communication. So, as we said, a good diagnosis of the radiology. If we look at this X-ray, we see that we have an infraoccluded first molar, and the orthodontist sent us this young patient to do the extraction. But when we analyzed why this tooth didn't erupt completely, we saw that there was a particular anatomy of the root, and also that the base of the sinus, the pavement of the sinus, was completely adjacent to the furcation area of the molar. And so when we performed the surgery, we also were ready to create and to close with a Rareman flap the closure of this communication. But this was diagnosed before we started the surgery, so we knew what we wanted to do after the communication. The Valsalva maneuver is something that we have to do during the surgery, but we also, very important to explain to the patient that they don't have to do this kind of maneuver in the days after the surgery, because once the patient goes home, he's going to make so many tests to see if this communication is still present or not. But without any control, the risk is of enlarging the communication by creating a strong pressure intrasinus due to this maneuver. So we have to just explain to the patient that this maneuver has to be done in the office in the presence of the doctor. So how do we manage a large oral antral communication? By performing a Rareman flap. This kind of flap is simply a flap where we have to cut the periosteum to elongate our flap to create a closure on the palatal aspect, which has to be epithelialized. So the epithelium of the mucosa of the palatal part of the flap has to be cut or grinded using a bar, so that we can actually attach the primary flap on the palatal part, and this will create a major adhesion. And as we see in this case, we have a large communication, both a buccal communication and occlusal communication. We place a sponge, we place a membrane to close the vestibular communication, and then we elongate the flap to perform the closure. But what happens when we have larger communications? In these cases, we have to go intentionally for the research of the pishabula. And in this case, we perform a Rareman flap, but in a double layer. So in the first layer, we're going to elongate and herniate the bola by pulling it, by searching it, and this is done by doing what we said we didn't want to do in order to prevent it from herniated. So we're going to look for it, and this is done using some scissors and going in the flap on the distal part, opening the flap gently, and this will expose the bola. And then with a blunt dissection, we're going to go inside the bola and herniate the bola to use it as a primary flap to close it, to go and suture it on the palatal aspect, as we see in this image here and in this image here, where the bola is sutured on the palatal aspect, and then we place the primary flap with the Rareman plastic surgery of the periosteum to close the secondary flap. And this usually blocks and closes the communication. What about the dry socket? The dry socket is something that gives some pain to our patient, and we still don't know the etiology of this kind of complication. It happens, we know that it has a major incidence in the female gender and in the patients with that use the oral contraceptive pill. What happens is that when we see the patient after 4 or 5 days from the surgery, we have a dry socket. So the socket is completely white. It usually smells bad, and the patient remembers this. And what we have to do is we have to curette and go and grind the bone. So we have to perform some anesthetic, local anesthetic, go inside the bony cavity with a round burr, and we have to go and make the bone bleed again, so that the alveolus, the bone cavity, fills with blood, and this usually gives a good resolution of the problem. So we have to give the antibiotics to the patient to avoid a secondary infection, but an interesting analysis found in literature says that antibiotic could prevent its onset of the dry socket, but the risk rate is of 0.4, and the number needed to take to avoid is 1 to 12. So we should prescribe a full antibiotic therapy to 12 patients to avoid one dry socket. So this is absolutely something we have to think about, because obviously the incidence of the dry socket is not so high, and also the resistance to our antibiotics is starting to getting a little bit wide in the population. So we will have to balance the risk factors of our patient in order to decide what kind of antibiotic therapy we have to do and we have to give before the surgery. And we will talk about this in the lecture talking about the preoperative drugs to administrate to our patients. What about the bony sequestrum? This is another problem that can occur, and it can occur for different problems, and these problems we're going to see in detail what they are. So how do we manage this kind of sequestrum? This is the X-ray that shows the area of sufferance of our patient. The patient went to his dentist, and for different visit, the dentist just prescribed antibiotics and mouth rinses, but the problem didn't actually resolve. So we saw the patient like this, we made our diagnosis, we performed our flap to expose the area, and every time we see this kind of sequestrum, we see this situation, this black area of the bone, which is a necrotic bone that remains in the area. So we have to remove completely this necrotic bone. We have to find the bleeding bone, so we have to find vital bone, and this can be done either using round bars on straight hand pieces, or we can use piezoelectric instrumentation. And this is the removal of the bone sequestrum, and then we place a collagen sponge and we close for primary intention. But what we know is that the soft tissues that surrounded that bone have suffered so for a while, and the healing is not always going to be as we wanted. So if we look at 1 week post-op, we see that there is still some sufferance of the soft tissues. And at 2 weeks, we have to remove partially this small soft tissue bridge that prevents and avoids the complete closure of our soft tissues. But once we remove that, after 4 weeks, the soft tissues are appearing healthy, and we like this kind of image. And this is the healing at 8 weeks with a complete healing of the soft tissue, and underlying we will have the maturation of the bone. Another case, another patient that refers to our office after many visits to her former clinician that performed the surgery, that gave her different kind of antibiotics, but the problem of pain and difficulty to eat wasn't solved by the therapy. So we perform a trapezoidal flap to expose the area. We see the area, and we create the good ways to resolve and to solve this kind of problem. We create and we find the black bone, as I told you just a couple of minutes ago, that we always find in this kind of sequestrum. We have to remove this bone with a bar or with piezoelectric instrumentation, and we have to find this image, which is the blood and the bone, which is vital and is bleeding. And this is very, very important to have a good healing. In this case, we made some rinses with some washes with rifampicin locally. We placed a collagen sponge, and we closed for primary intention. And this is a particular of the sequestrum that we removed. So, for bony sequestra, what do we have to do? Well, we don't have to leave too much the bone exposed after our surgery, so always try to create a primary closure or at least have periosteum covering the bone in the phases of healing. Perform an osteotomy and ostectomy under constant irrigation with cold saline solution. I always like to refrigerate the saline solution that I use to irrigate the phases of osteectomy, and then check the patient's systemic anamnesis, because the patient can either suffer from diabetes or have been exposed to radiotherapy or any other issue that can reduce and slow down the healing process of our surgery. So always read and look on the systemic conditions of our patient. So what happens if we lose the instrument's control? Well, this can create some problems, and so we can see if we lose rotary instrumentation, well, we can have this kind of problem. In this case, the loss of control of the bar was due to the fact that the bar was an old bar and didn't cut with the same efficiency as if it was new. And so what happens when we are using instrumentation that isn't efficient? We increase the pressure, and what happens when we increase the pressure? We lose control. And in this case, the bar cut the tooth and it made the odontosection that we wanted to do, but the surgeon didn't feel the end of the tooth and actually perforated and cut also the lingual aspect of the bone. And this led, fortunately for the patient and for the surgeon, to a perforation of the bone and the soft tissue, but this happened above the pavement of the tongue, and so it didn't go inside the area underlying the pavement of the tongue, where we have obviously vessels and nerves and important structure which could have led to a problem that maybe had to give the hospitalization to our patient. And if we look at the X-ray, the post-op X-ray, we actually see the area where the lingual part of the bone was cut due to a mistake of the surgeon. And what can happen if we lose control with sharpened instruments? Well, In this case, the colleague tried to perform a Rehrmann flap to elongate the flap, but with the blade, he cut the soft tissue too deeply, and this led to a laceration of the primary flap. And after 7 days, the patient came back in this condition with a bone exposure. And so we had to perform another surgery to go and reduce this area of necrotization of the bone. And we did this by creating a primary new flap, doing a new periosteal incision to elongate our flap. We see here the elongation of the flap, and this led to the primary closure of our wound. So always be careful when we use our blade to cut the soft tissue, to be superficial and to have control and not to go too deeply. But what can happen if we lose control of our luxation instrument? And this is something I always tell also to students and to colleagues, to young colleagues, is that they don't have to create too much pressure in the luxation movement. I always suggest to hold the lever with 3 fingers, and this avoids the fact of applying a force which is too strong. And as we said previously, if we apply a force which is too strong, we lose control. So always try to hold the lever with 3 fingers, and this is enough to perform the luxation. And another important thing is to have efficient levers that aren't too blunt and have also a little bit of a cutting effect to help us luxate our teeth. In this case, the tooth was luxated, but it was pushed in the surrounding soft tissue, and then the colleague got afraid, closed the flap, and when we performed our surgery, we found the tooth that was like floating in the soft tissue surrounding. And so this was done because of a loss of control. Another issue that can happen after 2 or 3 weeks is the early infection. This is not a late infection, it's after like 2-3 weeks, maximum 1 month. The patient comes back to remove the stitches and is very happy, the surgery went well, uneventful healing, but after 2 or 3 weeks he calls us back and tells us that he feels like a pressure behind the second molar, and that he sees maybe a little bit of pus coming out from the distal sulcus of the tooth. And when we see our patient, we tell them to come back, we get our probe, we probe distally, and we have pus exudation of the sulcus of the distal part of the second molar. So we we give a small shot of anesthesia, we open our small flap, access flap, just to see, and we always find in these cases the permanence and the presence of this small soft tissue that here is enlarged, which was left after the surgery, and this is the area of suturing once we close. Another case, very similar, probing, pus, opening of the flap. What we see is a small area of soft tissue. Well, in these cases, in all of these cases, what we see is that during the first surgery, not enough attention has been given to the part where we have to create a removal, a good removal and a good control of the soft tissue distal to the second molar, which is the area where we have the pericoronitis. We don't have to forget the majority of teeth extraction is due to pericoronitis, which is an inflammation of the soft tissue around our wisdom tooth. And that tissue distal to the second molar sometimes remain attached and it's not removed. And once that kind of tissue remains attached, it can lead to this kind of infections. So always be very accurate in checking once we extract our tooth that no small fragments of soft tissues remain distal to the second molar and inside the bony cavity. We can also have the dehiscence of the flap, and the dehiscence of the flap, like in this case, is mainly due to the position of the incision. We know that either we stay marginal to the part of the teeth, so in an intrasulcular incision, or if we decide to perform a surgery with a paramarginal approach, we have to remain quite either deep in the soft gingiva, not the keratinized gingiva, well below the mucogingival junction, or still up in the keratinized gingiva if we have enough. But don't remain towards the mucogingival line, because there we can have a strong use of the muscles of the area, which can lead and create this kind of dehiscence. In these cases, what do we have to do? We have to open our flap again, and we have to do a double layer suture. So we're going to close the periosteum and the muscular stratus first primarily with a resorbable suture, and then we will going to close the flap primarily on top of it, and this will create a good healing of the area. What about delayed healing? Have you ever had these kind of healings? Well, yes, these are two different types of healing. This is a delayed and not nice healing of our surgery, and this is a big hematoma that comes out of our socket. And these problems are mainly due to a bad management of the soft tissues. So we always have to treat gently our soft tissues, and we always have to use the correct sutures. And we will look at this when we talk about the instrumentation and the materials that we have to use, choosing the right instruments and the right materials for each patient. What about hematomas? Well, they're not always predictable, but they can give worries to our patient, because we have to tell them before the surgery, before they go home, in the instructions, that they can have a bruise on their skin, but this bruise can enlarge and create a real hematoma, which then can migrate towards the chin and towards the chest. Always tell them to use ice packs for the first day, half an hour with the ice pack, half an hour without the ice pack, and this is very important to reduce this kind of hematomas. And also try to sleep with a couple of pillows behind the head for the first night, not to have too much blood going towards our surgical site. But another important thing is always to look at the systemic conditions of the patient, because maybe the patient can have problems in coagulation, or can have a therapy with some drugs that can reduce the coagulation. So all these kind of information have to be checked and seen before the surgery, in order to tell them to the patient not to worry, and always to call us to be reassured of what is going on. So don't leave your patient alone. So intraoperative therapy, we have to look that there is no bleeding, as we said, and no hemorrhage. So place a wet gauze for a couple of minutes after the surgery and check that there is no post-op bleeding. Accurate evaluation of the anamnesis, as we said, and also reduce as we can, according to the type of surgery, releasing incisions that can lead to this kind of bleeding problems and a hematoma post-op hematomas. What about fractures? Well, fractures are a real small, luckily, kind of complication of wisdom teeth surgery, but they can occur in some circumstances. One kind of fracture, it's a quite common fracture, but it doesn't give major problems, is the fracture of the tuberosity, maxillary tuberosity, tuber maxillare. And this is mainly due to a wrong radiological evaluation. So we always try to check and see where and how the tooth is positioned. Another problem is due to the fact that we don't perform an odontosection, but we try to reinforce our luxation procedure, increasing the force. So always use gentle forces in luxation, create any bone sectioning or odontosectioning, tooth sectioning of the tooth to reduce the trauma, and this will reduce this kind of problems. And also the type of instrumentation that has been chosen has to be chosen looking at the patient we are performing the surgery on. So if we look at this kind of mandible, at this kind of jaw, we see that it is very small, very thin. This is an old lady that had a wisdom tooth that gave her dysphagia. She couldn't eat, she couldn't wear her mobile prosthesis, and she had some problems, so we had to perform surgery on this kind of patient. But what happens if we decide to use this kind of levers, which I usually use in certain conditions, and I will explain you in the next lessons how to use them, but these create very, very strong forces because they apply a third kind of leverage, and this can create the fracture of the mandible. So always use gentle luxation forces. This is very, very important. But is there a moment where there is a greater risk of fracture? Well, this can happen when we have patients with these kind of lesions that involve wisdom teeth. In this moment, when we have the lesion and the tooth is inside and the cyst or the tumor is pushing on the bony walls, well, this moment is not a risk of fracture. The risk of fracture usually occurs after 1 month we perform the surgery, because what happens is that when we remove the cyst and the tooth, we make the hole, the access of the bony wall to remove the two pathologies. And when we remove these lesions, which usually are under compression and keeps the bone under compression, well, we leave an empty area, and this moment of the empty area where the clot and the blood isn't still organized in a material which gives a little bit of strength to the mandible, is about 20 to 1 month after the surgery. When, and this is a problem of the patient and of the instructions that we have to give to the patient, when the patient forgets about the surgery that he had, and when he doesn't feel anymore the symptoms, the post-op symptoms, and starts to eat without thinking and without remembering that at that moment he has a fragile mandible. And so he starts to eat like big pieces of meat and starts to chew normally, and that is the moment of the major risk. So in this kind of surgery, always remember to explain to the patient that their diet has to be controlled and that they can't chew and use the normal forces they use to chew for the first month and a half. This is another topic, the injury of the nerves, of the inferior alveolar nerve and of the lingual nerve, but we will going to have a lesson just on this topic, so we will talk about this deeply in another lesson. I would like to conclude this lesson saying that when we can't manage the treatment of a complication, well, maybe we should refer the patient to a specialist, because although maybe we can manage the surgery itself, it is very important that we know how to prevent and manage the complication. Thank you for your attention.